invite all of you to the 83rd National Webinar on, it's a panel discussion on postpartum hemorrhage and obstetrician's nightmare. Our distinguished moderator for the day is Dr. Kunjamma Roy ma'am. Ma'am is a professor and unit head in the Department of Gynecology. Ma'am has more than 36 years of experience, and she was a previous HOD in the Department of OBG in Kottayam Medical College. She was General Secretary of the Indian Academy of Indian Reproduction for 10 years and was the President of the Kerala Federation of Obstetrics and Gynecology. She was entrusted with the task of assessing maternal mortality as part of a confidential review of maternal health in Kerala. She is a member of Federation of Obstetrics and Gynecology Society of India and UPSC Advisory Board. Over to you, ma'am, for the panel discussion.
Thank you, Dr. Prakash. Are you introducing Dr. Rekha and Kurula? Dr. Prakash?
Yes, ma'am. And our distinguished panelists for the day are Professor Dr. Kuruvilla P. Chacko. Sir has over 2 decades of experience in the field of OBG. And with him is another distinguished panelist, Dr. Rekha. Ma'am is Associate Professor in the Department of OBG in Believers Church Medical College Hospital. Welcome you all. Hope you have a nice session. Thank you.
Okay, thank you, Dr. Prakash, for the nice introduction. A very good evening to one and all who have joined this webinar. At the very outset, I would like to thank our beloved Director and CEO, Dr. George Sanders, sir, for giving us opportunity to present this topic before you. And also Dr. Prakash, Dr. Jacob, and the whole team for helping us to make it possible. We'll talk on postpartum hemorrhage. Definitely, it is an obstetrician's nightmare. I'll share the screen. Just a minute. Okay, as already introduced, my panel members are Dr. Kuruvilla P. Chacko and Dr. Rekha Murugan. See this picture, that's just a reminder of how the Pph is such a tragedy in almost everyone. Nobody is excluded. The beloved wife of Shah Jahan, Mumtaz, she also succumbed to death due to this Pph, which nobody could prevent it. Nobody could revive her. That's why this Taj Mahal is still remaining as a monument. So we have to remember certain important points before you go into the further details. Like, the Pph or postpartum hemorrhage is the most common cause of maternal mortality world over, and also in Kerala, as Prakash rightly pointed out, we used to conduct a confidential review of maternal death in Kerala. That also proves that postpartum hemorrhage is the most common cause, except these last 2 years where this COVID death ranked first. Otherwise, always Pph is the most common cause. And this can be managed by a variety of medical and surgical interventions. But the key to management is to recognize excessive bleeding before it becomes life-threatening. And also, it is important to identify the cause and initiate appropriate intervention based on the clinical setting, like the cause of bleeding and the severity of bleeding, whether the abdomen is opened or not. Another important thing we have to remember in this regard is that rapid deterioration. Rapid deterioration of, what's the problem?
Madam, slide.
Not seen us.
Not moving. The initial.
No. I am talking about this slide only.
No, only
the name is coming here.
Coming. No, the slides.
Slide. Kunjamma Kuruvilla Rekha. That slide is only coming.
Okay. What's the problem there? Just a minute. not moving. മാത്രമേ ഉള്ളൂ. Your screen sharing is post. No. നേരത്തെ മൂവ് ചെയ്തോണ്ടിരുന്നില്ല. Now can you see? അവിടെ കാണുന്നുണ്ടോ നോക്ക്.
Yes, ma'am. Ma'am.
Yes, ma'am. It's visible now.
Now it's moving.
No.
No, ma'am. It's not in slideshow.
Yes, it's in slideshow only.
Okay, ma'am.
Now can you see? Rekha?
Ma'am, it's the not as a slideshow. It's
Illa. Not moving.
next to third slide on it.
Recording in progress.
You can see
Now,
it now.
now how is it?
Yes, now it's a slideshow.
Now we can see.
Okay, so shall I repeat the thing which I have already mentioned? I think it is not needed. I'll go to this, okay?
Yes, ma'am.
As I have already told you, postpartum hemorrhage is an obstetric emergency and the most common cause of maternal mortality world over and also in Kerala, as per the confidential inquiry into maternal death conducted in Kerala. Here also maternal mortality, the most common cause is PPH, except the last 2 years where COVID death ranked first. And of course, you should remember that it can be managed by a variety of medical and surgical interventions. And the key to management is to recognize excessive bleeding before it becomes life-threatening. And of course, you have to identify the cause and initiate appropriate intervention based on the clinical setting, like find out the cause of bleeding and the severity of bleeding and see whether the abdomen is opened or not. Another important point you have to remember is that a rapid deterioration of maternal vital signs out of proportion to the vaginal bleeding that suggests that there could be internal bleeding or retroperitoneal bleed. It could be due to rupture uterus or rupture of the liver, as you see in severe preeclampsia and HELP syndrome, and also extended vaginal hematoma. So before you go into the management proper, just to memorize that there are certain hemodynamic changes that is happening in pregnancy, which is of some help in the management of PPH as well. So during pregnancy, it's a hyperdynamic, hypervolemic maternal circulation. And you know that cardiac output increased by 50%. And so because of that, only 30% of blood loss may be tolerated without any signs. So this serves the purpose of saving mothers against hemorrhage. But the problem is that delays the development of clinical signs like hypotension and tachycardia. So the diagnosis may be delayed and the initiation of management will also be delayed. So now coming to the question, my panel members will give you more details about some more things about PPH. First question is, what are the signs and symptoms based on the amount of blood loss?
Madam, thank you very much. Actually, the slide is not coming, madam. The clinical classification.
I don't know, here it is moving. Maman is trying some other way. You can't see the slide?
No, madam.
I don't know what's the problem? But the slide is not moving. And I've seen there, if here it is moving. Sorry for the interruption.
I will write it. Unmute.
Yes, ma'am. The slides are changing. Yes, ma'am.
Okay, okay. Video also? Moment, this is not moving.
Hello?
Okay. Prula,
Yes, madam. Yeah.
tell me, what are the signs and symptoms based on the amount of blood left? Sridhar madam, sorry for the inconvenience, no? Some problem with the slides. Okay.
This happens always. Don't worry.
Okay, and let's go into the clinical classification by Benedict in 2002, where it has been classified according to the percentage of blood loss and classified into 4 classes. Class 1, where the blood loss is about 15% and the blood loss is around 1000 when there is mild tachycardia. Class 2, when the blood loss is around 20 to 25% and blood loss of 1500, which causes postural hypotension, tachycardia, and tachypnea. And the next is when the stage class 3, where 30 to 35%, almost 2 liters of blood has been lost, then there will be overt hypotension, tachycardia, oliguria, and cold clammy extremities. And class 4, where the patient has lost almost 40% of blood, that's almost 2400 ml, and the patient will be in profound shock. Yes, ma'am.
Knowledge of this is very important to identify in which class that lady belongs to, and you have to initiate treatment accordingly. See, another scenario is that I will be presenting a case scenario. You are called for a woman who has just given birth, delivery performed by junior resident. Upon arrival, patient is pale and the bed is soaked in blood with tachycardia and falling BP. What's the diagnosis?
The diagnosis is postpartum hemorrhage. By definition, traditionally more than 500 ml of loss after vaginal delivery or more than 1000 ml after cesarean section is called postpartum hemorrhage. For clinical purpose, any blood loss that has the potential to produce hemodynamic instability is considered as PPH. There are 2 types of PPH, primary or early and secondary or late according to the time of onset. Primary occurs within 24 hours of delivery and 70% of cases it is due to atony. Secondary or late occurs after 24 hours of delivery and within 6 weeks postpartum. Another classification is into minor and major, where minor pph is 500 to 1000 ml of loss and major pph is more than 1000 ml loss.
What are the causes of this postpartum hemorrhage?
The causes of postpartum hemorrhage is remembered as 4 T's: tone, trauma, tissue, and thrombin. And the tone is regarding the tone of myometrium, trauma to the tissues, and the presence of placental tissue causing pph, and last one is thrombin, that is coagulation. Let's see the causes and risk factors of tone. Over-distended uterus is the cause of tonicity. It may be due to multiple pregnancy, macrosomia, or polyhydramnios. Labor abnormalities like too rapid labor and prolonged labor, chorioamnionitis, and prolonged oxytocin use, and the presence of fibroid, inversion, obesity, and previous history of postpartum hemorrhages. And let's see the causes and risk factors of tissue. The placental causes are sexcenturate lobe, incomplete placental expulsion, trapped placenta, placenta adherens, and placenta accreta spectra. Risk factors are the preterm births, use, defective placental implantation, previous uterine surgery, and history of pregnancy. Let's look into the causes of trauma. It may be due to an episiotomy, from instrumental delivery, the vaginal tear and difficult labor, assisted breech delivery, and cesarean section, rupture of uterus, which may happen in trial of labor after cesarean, and high parity and inversion of uterus. Always you have to think about thrombin as a cause in case of preeclampsia, abruptio placentae, amniotic fluid embolism, iatrogenic anticoagulation with drugs, and fetal death.
Okay, thank you, Gurula. He has described in detail the 4 T's leading to a pph after delivery. So now the problem is, see, when you are called to attend a patient with bleeding, if there is excess vaginal bleeding following a normal vaginal delivery, in spite of active management of 3rd stage of labor, that patient should be attended by an obstetrician or a provider who is capable of doing a proper evaluation and also initiating the medical and surgical management at the earliest. So how do you start off with initial resuscitation?
The management of pph includes initial resuscitation and specific management. Initial resuscitation, we should give the call for help. The people who should be intimated are senior obstetrician, anesthesia team, blood bank, laboratory staff, ICU staff, hospital attendants, and theatre staff. We should have an informed guess regarding the possible cause and act immediately. Do not wait to identify the exact etiology. Go for medical management and transvaginal uterine artery clamp simultaneously. Medical management includes oxytocin, uterine massage, and tranexamic acid. Assess the patient. Assess the ABC, that is the airway, breathing, and circulation. Airway, maintain the patent airway. Breathing, ensure a SpO2 level of more than 94% by giving oxygen by non-rebreathing face mask at 15 liters per minute or 6 to 8 liters per minute by nasal cannula. C is circulation. Fluid resuscitation should be given. Choice of fluid is always crystalloids. 1 liter should be given in 15 to 20 minutes by 2 wide-bore cannula. The wide-bore cannula are either 14 gauge or 16 gauge, that is the red and the grey one. Blood should be sent for investigations including blood grouping and cross-matching, complete blood count, coagulation profile, serum fibrinogen, renal function test, and liver function test.
See, I'll explain about this transvaginal uterine artery clamp because it has recently this about an article about the use of transvaginal uterine artery clamp has come in a European journal. This was developed by our own Pfizer from Dagagiri. Since 2009, he has been using this, and based on that, he has published an article which was accepted by the European journal and is published last month. So you have to know something about that. What is it? It's a transvaginal uterine artery clamp. It's about 28 centimeters, like from here to here to here, it is 28 centimeters, and this upward curve, it's about 2.5 centimeters. And there is a 1 centimeter gap between the blades. And the bent tip of the clamp, it's about 1 inch height, already mentioned. See, how does it arrest bleeding? That's the thing. See, we know the circulation and the pattern of uterine artery entry into the uterus and how it ascends out. So when you insert this clamp and in the lateral fornix at 3 o'clock and 9 o'clock position, both sides you have to clamp. So you reach the fornix and then further 1.5 centimeters pushing upward, that will block the uterine artery here. Occasionally, this may include the uterus, but still there is no problem because once you release it, it will be all right. So far, no problem of ureteric occlusion or nothing has happened so far since these many years. So this occludes the uterine arteries, and arrest of flow through uterine arteries have been demonstrated by ultrasound and Dopplers. That's why we still continue to use it. So after release of the clamp, the blood flow restores. That's the advantage of it. Then how to apply? We have to expose the anterior and posterior lip of expose the cervix by catching hold of the anterior and posterior lip of the cervix. And then you take the clamp at, this is at 9 o'clock position, here it has to be at 3 o'clock position, and just insert into the fornix, deep into the fornix, and after reaching the fornix, just a push upward for one more, 1.5 centimeters, then definitely it will block. The advantage is that once the uterine artery is blocked, then the bleeding will be arrested, then you can look for the etiology or the cause of this excess bleeding and do along with the medical management, as Reha has rightly pointed out. Once the bleeding is arrested, then identify the etiology and 30 minutes. And if there is further bleeding, you open and leave the clamping position for further 20 to 30 minutes. If no further bleed, you can remove after watching for a few minutes. And if there is further bleeding, reapply clamp and consider. Then this is the first line surgical intervention in case of postpartum hemorrhage. Then if this fails, you can go for second line surgical interventions like suction cannula or contaminate or mechanical methods. So the set, all labor rooms should have this transvaginal uterine artery clamp set. The prerequisites, we need good lighting and good analgesia and good assistance. So this contains 2 spondyloline forces to catch hold of the anterior and posterior lips of the cervix, and 2 clamps and 3 deep vaginal tracheids by which you are retracting the vagina to expose the cervix. It's very simple. So I think everybody should use it. All laboring, all unit with delivery should have this clamp, and immediately that should be used, and all the staff in the labor room should be trained accordingly. The next question is, see, already Kurula has described that if it is 20 to 25% blood loss, it's almost corresponding to 1,500 ml. If it is less than 1,500 ml of blood loss, and if there is uterine atony, how do you manage?
Okay, madam. So here we are going to see how to manage when the blood loss is less than 1,500. So the most important thing that you have to note is the calculation of blood loss by visual means always is underestimated. So we have to always think and assess the signs of severe postpartum hemorrhage. Always look for tachypnea, tachycardia, blood pressure less than 90, systolic, altered mental function, and it shows a loss has happened more than 1,500. So multidisciplinary team approach is always to be practiced. Communication is very important, and events should be recorded by a dedicated person. And here we have to use a combination of pharmacological, mechanical, and surgical methods. It is aimed to correct the causative factor and to stimulate myometrial contraction. The management pillars are to arrest bleeding, correction of loss, and to prevent organ damage. Pharmacological management, as we know, are oxytocin, carbetocin, methyl ergometrin, carboprost, prostaglandin E1, and tranexamic acid. Let's look into the dosage. Oxytocin acts through the oxytocin receptors where the half onset is within 1 minute, and the dose is 10 to 20 units in 500 ml of saline at 60 drops per minute. and maintenance of 10 units with 40 drops per minute, and oxytocin needs refrigeration. We have carbitocin, which has a synthetic analog. It takes about 2 minutes to act, and 100 micrograms in 1 ml IV or IM has to be given. The good thing is it is temperature stable and single dose is recommended. When we look into methogen, it is alpha antagonistic vasoconstrictor, and it acts in 2 to 5 minutes. 0.2 milligram IM or IV, which we can repeat after 15 minutes. And it also needs refrigeration, but contraindicated in preeclampsia and heart disease. Carboprost is the other wonder drug, which acts on prostaglandin receptor, which can be given intramuscular, 250 micrograms, and we can repeat every 15 minutes to a maximum of 8 doses, which needs refrigeration and should not be given to an asthmatic patient. And prostaglandin E1, which acts on prostaglandin receptor, can be used in sublingual, oral, vaginal, rectal, and can be used up to 800 microgram, which is very commonly used. Next wonder drug is the tranexamic acid, which is antifibrinolytic agent, which we give as 1 gram in 100 milligram per ml over 10 minutes, where the half is 11 hours. We will go to the mechanical methods. When failure of pharmacological methods has been seen, then immediately we will think about mechanical methods. So use of intrauterine balloon tamponade is the regularly used one with contaminant. The other things can be Foley's catheter, 24 gauge, Beckery's balloon, and Sengstake Blackmore tube. The contaminant picture was given on right side. The most important another technique is a vacuum induced uterine tamponade. This will help to suck out the blood clots and keep the uterine surface over the cannula. The picture of vacuum retraction cannula is being shown here, which we have recently started to use with good success rate. And uterine packing is the next technique, which compresses the bleeding surfaces. We can use either a plain gauze, laparotomy sponge, hemostatic gauze, or a compressed mini sponge for uterine packing. If the bleeding is arrested by the mechanical methods, it's a good sign, so laparotomy is not indicated. Hence, mechanical methods are considered as a first line management, and we have to keep it for 4 to 6 hours, and preferably we should try to remove only during the daytime.
See, mechanical method, it is considered as the first line surgical method. Along with that, you have to add this pharmacological method, and initially you have to do all the investigations as mentioned earlier. Then regarding this tranexamic acid, there is a trial called Women Trial, World Maternal Antifibrinolytic Agent Trial. See, this trial result, the result suggests that about 31% of reduction in maternal death has occurred if tranexamic acid is used within 3 hours of delivery. And if bleeding is not controlled, you can repeat it after 30 minutes. That's the advantage of tranexamic acid. So don't be like hesitant to use tranexamic acid, which we had that resistance earlier. Okay, coming to the next situation, if the blood loss is more than 1,500 ml, that means about 30 to 35% of blood lost. How do you proceed?
A systolic blood pressure below. (1,500 ml). Okay. Shock index. It's calculated by dividing heart rate by systolic blood pressure and is used to detect the severity of hemodynamic instability and hypovolemia. A shock index of less than 0.9 provides reassurance, whereas shock index more than 1.7 indicates need for urgent attention and predict an adverse outcome. In low resource settings, this simple parameter would improve the outcomes. A multidisciplinary team involving a senior consultant obstetrician and anesthetist should be summoned to attend to the woman with major Pph and ongoing bleeding or clinical shock. The blood bank should be informed. One member of the team should be assigned the task of recording events like administration of fluids, drugs, blood and blood components, and also recording of vital signs. Resuscitation, monitoring, investigation, and treatment should be done simultaneously. A and B, assess the airway and breathing. C, evaluate the circulation. Position the patient flat. Keep the woman warm. Transfuse fluid as soon as possible. Until blood is available, infuse up to 3.5 liters of crystalloids. Major obstetric hemorrhage protocols must include the provision of emergency blood with immediate issue of group O negative with a switch to group specific blood as soon as feasible. Immediate venipuncture should be done and about 20 ml blood is collected and sent for cross match minimum 4 units. Complete blood count, DIC panel including prothrombin time, activated partial thromboplastinogen time, fibrinogen, thrombin time and D-dimer. Liver and renal function, serum electrolytes and arterial blood gas analysis. Monitor the temperature every 15 minutes. Continuous recording of pulse, blood pressure and respiratory rate should be done. Polis catheter should be inserted to monitor urine output. 2 peripheral cannulae, preferably of the 14 gauge, should be there. Consider putting a central line.
So, concerns in acute coagulopathy and hemostatic resuscitation, they have already mentioned that up to 3.5 liters of crystalloid is infused immediately. But the problem is, if patients with crystalloid or PRBC-based resuscitation will develop dilution of clotting factors and platelets. That's the problem. That will lead to dilutional coagulopathy, hypothermia, and acidosis. So that will further, cause more problems for the patient who is already on on treatment for this PPH. So it worsens bleeding by increasing the intravascular hydrostatic pressures and dislodging fresh floats at sites of endothelial injury. And so excessive amounts of crystalloids that will lead to cerebral, cardiac, and pulmonary edema due to third spacing. So we have to be very careful in this fluid overload. And recent studies suggest that acquired fibrinogen deficiency, dilutional coagulopathy, and hyperfibrinolysis, they are the major coagulation abnormalities in obstetric hemorrhage. So we have to follow a protocol-based empirical replacement of coagulation factors that is recommended in massive blood losses. So we have to know what should be given and in the amount to be given and when it should be given based on the investigation results. So you have to follow this massive transfusion protocol or MTP. The protocols are activated by the clinician in response to massive bleeding, usually after 4 units of PRBC transfusion, and there is ongoing bleeding. See, these MTPs or massive transfusion protocols have a predefined ratio of RBCs, FOP or cryoprecipitate, and platelet units. Example 1:1:1 or 2:1:1, and some institute they follow 6:4:1. So that's decided by each institution. Once the patient is in the protocol, the blood bank ensures rapid and timely delivery of all blood components together to facilitate resuscitation. That's very important to save these patients. And we should have a target of resuscitation in this massive blood loss. The MAP or mean arterial pressure should be around 16 liters of mercury, and systolic arterial pressure 80 to 100 millimeters of mercury. But in hypertensive patients, one may need to target higher MAP. And the hemoglobin level should be maintained between 7 to 9 grams per dl, and the INR should be less than 1.5 or APTT less than 42 seconds. And the fibrinogen level should be more than 1.5 to 2 grams per liter, and the platelets more than 50,000, and the pH should be maintained at between 7.35 to 7.45, and the core temperature should be more than 35 degrees, and the base deficit should be less than 3 per lactate and less than 2 milliequivalents per liter. So these things we have to monitor. People capable of monitoring all these things should be available in the management of massive blood loss. So in this situation, when there is excess bleeding, when will you consider angiography and selective embolization? How far it will be of use? Now we have interventional radiologist, Dr. Tom. So then we'll have to go for this as well. How far it will be of use?
Okay, here for arterial embolization, we always do for hemodynamically and hemostatically stable patient who have persistent, slow but excessive bleeding and who have failed less invasive therapies. So here we have to avoid delay. After first line treatment fails, go for angiography plus transarterial embolization when the patient is hemodynamically stable. Earlier embolization reduces the blood loss and clear the operative field. During primary postpartum hemorrhage, embolization should be done before laparotomy. In cesarean section, but we in the intraoperatively itself we ligate the uterine vessels. In postpartum hemorrhage, the transarterial embolization can be done. Secondary postpartum hemorrhage, the embolization can be done as a first line management also. So here, how do we technical considerations are femoral artery is catheterized and pelvic vessels are assessed. Then angiography followed by embolization of the bleeding vessels is being done. Here we use gel form, which is absorbable gelatin sponge, or another material called NBCA, N-butyl cyanoacrylate, which we can use even in DIC. As a general rule, we try to do the bilateral uterine vessel embolization, regardless of the active bleeding foci point. And when the embolization of uterine artery fails, we go for embolizing the anterior division of internal iliac artery, where or in post-hysterectomy patients. Embolization of the anastomosing vessels will be done if both uterine artery and internal iliac fails. The success rate is around 86 to 95%, but the failure is more if there is DIC or hemoglobin is less than 8 or the patient is hemodynamically unstable. The disadvantages are she will be exposed to radiation, there is a chance of deep vein thrombosis, there is a chance of ischemia, endometritis, and uterine necrosis. The uses, as we know, it can be used for postpartum hemorrhage caused by atonicity or traumatic postpartum hemorrhage or retained placenta, and most important, we can use even for arteriovenous malformations. The percentage chance of rebleeding is 5 to 13%, and transarterial embolization can be repeated.
So here certain important points, as he rightly pointed out, that this is useful for hemodynamically and hemostatically stable patient, but still she is continuously bleeding, not massive bleeding, but continuously bleeding, that is excess more than normal. So in such situation, you can go for this embolization. And of course, we are able to save mini uterus, especially in secondary PPH for a primary para. See, we can save the uterus by doing or going for this uterine artery embolization. That's the advantage of it. Since wherever it is available, it's better to go for that. Then next question is, see, the bleeding is ongoing, massive bleeding. Then when will you decide on laparotomy? At what stage?
In atonic PPH, when medical management and mechanical methods fail to arrest bleeding and the patient is hemodynamically unstable, never be hesitant, go for laparotomy. Even when patient is hemodynamically stable, but facilities for uterine artery embolization is not available, then also we think of laparotomy. Other indications are in traumatic PPH, when there is extensive cervical or vaginal lacerations with severe bleeding. In case of deep vaginal tear causing colporexis, cervical tear extending up to the fornix, when you suspect a supraelevator hematoma or broad ligament hematoma, and in cases of rupture uterus. The surgical management include stepwise devascularization. Can put compression sutures like Wheeling, Heyman, Cho suture, or followed by internal iliac ligation, and finally if hysterectomy. The stepwise devascularization includes unilateral uterine artery ligation. If it fails, followed by bilateral uterine artery ligation, then low uterine vessel ligation, unilateral utero-ovarian anastomosis ligation, and finally bilateral utero-ovarian anastomosis ligation. Preferably go through a vertical incision for this. For uterine artery ligation, first exteriorize the uterus, push the bladder down, put the fingers behind the uterus, and take suture bite close to the uterine myometrium and come out through a avascular space in the broad ligament. Similarly, for utero-ovarian artery ligation near the corneal region, go through the myometrium and come out through the avascular space in the broad ligament and ligate the utero-ovarian anastomotic vessel. The uterine compression sutures are the B-Lynch sutures, Hayman sutures, and the Cho sutures. They act by compressing the anterior and posterior uterine walls without occluding the uterine artery. So that is a tamponade test. We can just compress and see whether the bleeding is stopping. The drawbacks of B-Lynch sutures are it needs hysterectomy. The uterus has to be opened, and the steps are difficult to remember in case of an emergency. The suture might slide off or slide in, and too tight B-Lynch might cause uterine folding or inversion. So there is a Hayman's modification where we don't have to do a hysterectomy. We can just take a suture through the lower segment of the uterus and just go around the uterus and put it. Cho sutures are square stitches. It is taken by needle through the anterior wall at or opposite the side of bleeding sinuses, brought out through the posterior wall and reinserted postero-anteriorly and tied. They compress the uterine walls by closing the sinuses.
So then you have to remember that if the first line and second surgical line fails along with pharmacological therapy, immediately you have to go for laparotomy. Don't wait or don't delay. The next question is, what's the role of internal iliac ligation in PPH? You have opened the abdomen.
Okay, it was first described by Kelly. It's a life-saving procedure in expert hands. So here, internal iliac artery is the main blood supply of the pelvic structures. So the mechanism, how it acts is it reduces the blood flow by 80%. And so the pulse pressure and mean arterial pressure reduces by 25 to 50%. Thereby, it converts arterial system to venous system, leading to stable clot formation and hemostasis. So we can use for atonic, postpartum hemorrhage and traumatic hemorrhage and placenta accreta spectrum and primary and secondary postpartum hemorrhage. So how do we do this? After opening, we have to identify the ureter and identify the internal iliac artery. And the most important step is pass mixture from lateral to medial side. Once you have passed it, then you ligate the vessel with 3 nodes with non-absorbable sutures. So before and after that, we palpate for the femoral pulsation to know whether we have accidentally obliterated the external iliac vessel and ensure hemostasis. The complications are the injury to vein, which may happen, which is very near to that, injury to ureter, obviously, and next is thrombosis, which may happen.
So here you have to remember that Kurula has said like it will reduce the pulse pressure and thereby reduce the blood flow. But he has mentioned the indication as PAS as well, placenta accreta spectrum. But the problem is this occlusion or this reduction in venous pressure that may be compromised when there is extensive collateral circulation. See, sometimes there are reports stating that there will be refilling of the internal iliac vessel beyond the point of ligation because of supply from the branches of external iliac artery like inferior epigastric and like that. So that's why in placenta accreta spectrum, this internal iliac ligation may not be of use. That's why we are going for this aorta plant or the common iliac clamp, where we occlude the lower end of aorta or both bilateral common iliac artery. Temporarily we are blocked so that the blood supply to the lower segment or the uterus can be reduced, and we can go ahead with hysterectomy or separation of bladder in case of placenta accreta. That point you have to remember. So the next is the trauma. How do you repair genital tract trauma?
The traumatic PPH can be due to trauma in the perineum, vulva, vagina, or the cervix. The perineal trauma can be type 1, 2, or 3, or 4 perineal tear. In the vulva, it can be laceration, hematoma, or paraurethral tear. In the vagina, superficial tears, deep tears, episiotomy extension, and hematoma. And the cervix, lateral tears, annular detachment, anterior lip or bucket handle tears, and lower segment PPH. So the possible sources are the cervical tear, vaginal tear, vulval and perineal tears, and the episiotomy. All of these can lead to paravaginal hematomas. The infralevator hematoma include those of the vulva, perineum, paravaginal space, and the issue fossa. And in case of supralevator hematoma, the bleeding is more dangerous and bleeding occurs into the retroperitoneal space and can be massive. This is a picture showing a broad ligament hematoma. The uterus you can see on the one side, and that next side you can see a broad ligament hematoma. Bleeding that occurs despite a well-contracted uterus with a steady loss of fresh red blood. Think of a trauma somewhere. Upper vaginal and cervical tears requires examination in the lithotomy position with good relaxation, good light, and proper assistance. Cervical inspection is carried out by grasping the anterior lip of the cervix with one ring forceps and place a second ring forceps at the 2 o'clock position, followed by progressively leapfrogging the forceps ahead of one another until the entire circumference has been inspected. Repairing the vaginal and the perineal tear. First suture is inserted above the apex of the tear or the episiotomy incision. Try to reach the full depth of the tear in order to reduce the risk of subsequent hematoma formation. Identify the bleeding vessel and ligate it. If the vagina is too friable to accept suturing, then packing is indicated. Lacerations high in the vaginal wall and those extending up from the cervix may involve the uterus and may need laparotomy. The proximity of the ureters to the lateral vaginal fornices and the base of the bladder to the anterior fornices must be kept in mind while suturing. Poorly placed stitches can lead to genitourinary fistulas. So vaginal packing for at least 24 hours is always wise under these conditions. Polis catheter should be inserted and broad spectrum antibiotic cover should be given where packs are used. Coming to repair of cervical tear, a bleeding cervical tear and any tear longer than 2 cm should be sutured by using an absorbable suture. Caudal part of the laceration is grasped with a ring forceps and then sutured with an interrupted or figure of 8 stitch. This is then held with a hemostat to bring down into view the next part of the tear, which is sutured in the same way and so on until the apex is secured. Urgent resort to laparotomy is necessary if there is a cervical tear extending beyond the internal os or if uterine rupture is suspected. Timely diagnosis and early intervention can save the mother in the case of a uterine rupture. In such cases, uterine repair or hysterectomy may be needed. Coming to hematomas, infralevator hematoma, if it's less than 5 cm, conservative management can be done. Edges should be marked. If it's more than 5 cm and expanding, surgical intervention is needed. Incision is made in the vagina and figure of 8 stitches is taken, followed by vaginal pack, Foley's catheter, and IV antibiotics. In case of a supralevator hematoma, if the patient is stable, we can do a close observation, IV fluid resuscitation, and blood transfusion. But if the patient is unstable, active intervention should be needed. And this includes either selective arterial embolization or laparotomy with or without total abdominal hysterectomy or internal iliac ligation.
See the third T, retained products. How do you manage retained placenta tissue? That's the third T.
Okay. So when we look into the retained placenta, we know that it affects almost 1 to 2% of all deliveries. Usually the placenta gets expelled in 30 minutes, and some causes which may be causing this retained placenta may be bits of placenta remaining inside, as in succenturiate lobe, or in a trapped placenta, or placenta adherence, or morbidly adherent placenta. So in this ultrasound image on left side, you can see that uterine cavity is empty with a thin endometrium. That's normal. So when you look at the right side, we can see that there is a mixed echogenic mass after delivery, which you can see inside the uterine cavity. That means some tissue has been retained inside. And how do you manage So we go by expected management. In the absence of bleeding, we wait till 15 minutes to 60 minutes. 1 hour we wait. But if bleeding is present, then we will start the initial resuscitation as already mentioned. So if bleeding is there, it's an emergency. Trapped placenta, we give uterine relaxants and use controlled contraction to remove that. If it is not coming out, to manual removal of placenta, but remember, there may be an unexpected morbidly adherent placenta. So the complications can be postpartum hemorrhage, it can happen early and late, endometritis and sepsis, subinvolution and placental polyp. So the role of bedside ultrasound in the postpartum management we are going to discuss. It will help to know whether there is any retained products, whether there is any lower segment postpartum hemorrhage, any broad ligament hematoma, and it will rule out rupture uterus. So regarding this lower uterine segment atony, which we are seeing nowadays, and this primary atony of the lower uterine segment appears to be a distinct cause of postpartum hemorrhage, which has not been well described in our obstetric literature. So when you have a well-contracted fundus and upper uterine segment and ballooned out lower uterine segment, which we can assess by vaginal examination, this lower segment uterine atony may be the cause of postpartum hemorrhage. Ultrasound will help us. You see in this picture, the upper part on the left side, you can see a well-contracted uterus with a thin endometrium and a good myometrium, which is well opposed. But in the lower segment, you can nicely see that lower segment is distended with some blood clots inside. That means it's a case of lower segment atonicity.
Now the key, thrombin. We will discuss that also. How do you manage if there is disseminated intravascular coagulation that is due to thrombin only?
So disseminated intravascular coagulation, it's a lethal coag. Bleeding can lead to coagulopathy, electrolyte imbalance, hypothermia, and acidosis. For the diagnosis of DIC, there should be clinical features and lab features suggestive of coagulopathy like prolonged prothrombin time, prolonged activated partial thromboplastin time, thrombocytopenia, and low fibrinogen. These lab findings should be interpreted in the context of normal values in pregnancy. And thrombocytopenia, the normal value is 1.5 lakhs. Prolonged PT will evaluate the extrinsic pathway of coagulation, and prolonged APTT will evaluate the intrinsic pathway. Both are prolonged in case of DIC, but in normal pregnancy, they are slightly lower. A widening difference between the baseline and repeat test indicates a clinical worsening. Thromboelastography, this helps in a rapid global assessment of the hemostatic function, allows more rapid diagnosis and intervention in patients who develop DIC. Another thing is the ROTEM or rotational thromboelastometry. Viscoelastic properties of clot formation and dissolution is assessed. It's superior to coagulation test and it's a rapid assessment of the coagulation pathway. Coming to the management, resuscitation, notify anesthesia staff, transfusion service, and laboratory. IV access should be inserted and IV fluids with 2 large IV cannulas. Start crystalloids before the blood arrives. Try to maintain a systolic BP more than 90 millimeters, mean arterial pressure more than 65 millimeters of mercury, and urine output more than 0.5 ml per kg per hour. Blood bank should be informed and massive transfusion protocol should be activated. Laboratory studies should be repeated every 30 minutes. Replacement of packed RBCs, platelet, and cryoprecipitate should be done in the ratio 1:1:1. Hypothermia can cause massive myocardial ischemia and promote coagulopathy. So avoid hypothermia and acidosis by using blankets, warming devices, and warm IV fluids. Manage electrolyte imbalance. Hypercalcemia impairs coagulation and increases risk of myocardial infarction. So 1 to 2 grams of calcium gluconate IV over 2 to 3 minutes for every 4 units of PRBC transfused should be given. Hyperkalemia can result from rapid transfusion of large volumes of packed red cells. and high potassium levels more than 6 milliequivalents is treated with 10% dextrose in 10 units of regular insulin. With 10 units of regular insulin. Tranexamic acid 1 gram can be given IV, taking about 10 minutes. The women trial found tranexamic acid reduced the bleeding by about 20 to 25% among women with postpartum hemorrhage. Peripartum hysterectomy, this should be initiated earlier than later. It is desirable but not always possible to correct the coagulopathies prior to the surgery. If bleeding persists after resuscitative measures, prompt decision should be taken for laparotomy. Maintain an oxygen saturation more than 95%. If not possible, go for mechanical ventilation. Fibrinogen, if it is less than 200 milligram percentage, it's an indication for cryoprecipitate transfusion. And if it's less than 100 milligram percentage, should be treated with 10 units of cryoprecipitate. Cryoprecipitate, each unit is manufactured from a single unit of fresh frozen plasma. It contains about 150 milligram of fibrinogen and 100 units of factor 8 and Von Willebrand factor. 5 units are pooled, and the usual dose is 2 pools, which will generally raise the fibrinogen by 1 gram per deciliter. And the target is hemoglobin 7 and try to maintain it between 8 and 10. Fibrinogen more than 2 gram per deciliter, platelet more than 50,000, prothrombin time less than 1.5 of the control, and APTT less than 1.5 control.
So here again, as I have already mentioned, you should be aware of when to give cryoprecipitate, when to give this FFP and like that. If you want to raise the fibrinogen level to 200 to 300, fresh frozen plasma will not be of use. There you have to transfuse cryoprecipitate. But if the level of fibrinogen has fallen below 100, then you have to give fibrinogen concentrate. Of course, the thing is factor 7A, recombinant factor 7A, but it's very expensive, and I don't know whether it is available here. Say there again, the fibrinogen level should be maintained above 50 to 100, and the hemoglobin should also be more than 8, and the platelet should be more than 50,000. And there should not be any hypothermia. These are the conditions to be satisfied before you plan for recombinant factor 7A. That's mainly used for hemophilic patients. Now, after having discussed the 4 keys, the cause of postpartum hemorrhage, the major killer, now the question is always, we know that prevention is always better than cure. So now the next few minutes, we will be discussing how we can prevent this PPH. That's the next thing. See, we have to prepare these pregnant ladies antenatally itself. We have to prepare every woman for possible PPH. How to anticipate PPH in every delivery, even low risk patients. At any moment, she may become high risk and she may bleed profusely. And you have to take prophylactic steps in every delivery. That is active management of 3rd stage of labor, which will definitely reduce the atonicity, and excess blood loss can be very much reduced. And of course, at the first sign of PPH, you have to take steps to stop bleeding, as we have already discussed. Then how do you prepare these pregnant ladies for possible PPH? That preparation includes, that should start antenatal period. So we have to have an antenatal class for all pregnant ladies along with their bystander who wants to be as the labor companion at the time of delivery. So we have to make sure the patient is informed about the possibility of PPH in every case. And you have to make her fit hematologically. That means you have to identify her anemia and treat it. And you have to know the blood group. And the hemoglobin level should be maintained at least 11 grams when she comes for labor. Then patient and family should have a potential blood donor identified, because even with normal hemoglobin, she may bleed due to atonicity or trauma. So that also should be arranged. And you have all these antenatal patients should have an antenatal card. And if there are any high risk factors, that should also be noted and highlighted in their antenatal card. Then in the labor room, what are preparations? You have to have an alert system. That's why this ORRT, that's the obstetric rapid response team. Every labor room should have, or department should have ORRT team. But since we have this code blue system, we are depending on that right now. And personnel who are involved in that should be aware of the causes of PPH, and immediately they should be able to evaluate and initiate the treatment. And the equipments to be made available for managing this PPH. In every labor room, we should have a PPH box, a cervical inspection set, a transvaginal uterine artery clamp set, a content emerald set, and a suction device. So the contents of the PPH box, it's written a cannula of 3 size, 2 each, and IV drip set, and 2 blood transfusion set, and IV fluids, normal saline should be there, syringes of varying size, 10 ml, 2, 5 ml, like that, and all the tubes to collect blood samples for lab work, and armband, and so many things all written there. But the important thing is that all these medications and all the things, every day the sister in charge of that labor room or whoever is in charge of this box should check and see whether the drugs available in that is outdated or not. And they should maintain a register where every day they have to put their signature, so that they will be responsible for that. And the drugs to be kept in the fridge, that should be with a special label. And in labor, the preventive measures are you have to avoid unnecessary inductions and augmentations. Then you have to maintain a partogram. You have to avoid unnecessary vaginal examinations and avoid fundal pressure, and instrumental delivery only if indicated. And of course, definitely you have to follow this active management of third stage of labor. And that's very important to reduce blood loss in normal third stage. And it will also shorten the third stage. And by that, it will reduce the occurrence of PPH. And in the postpartum period, that's very important. You have to have a strict monitoring at least for 2 to 4 hours. And every half an hour, you have to monitor the pulse, blood pressure, and the state of the uterus, whether it is relaxed or not. And of course, you have to look for any vaginal bleeding. And even in the earliest evidence of PPH, take proper steps to arrest bleeding. So to conclude, the treatment goals are to restore and maintain adequate circulatory volume, to prevent hypoperfusion of vital organs, and also to restore or maintain adequate tissue oxygenation, and reverse or prevent coagulopathy, eliminate the obstetric cause of PPH. These are the aim. So for this, what I would suggest is that a proper training and simulation is very much needed. All the obstetric staff, not only the doctors, all staff should undergo a team training to teach the staff to work together and communicate more effectively when PPH occurs. That's very, very important. See, right from the beginning, call for help. Everybody should be aware of all the things that should be done for evaluation and further initiating the further management. And for that, it is always essential to conduct clinical drills to help staff prepare for PPH. And also, we have to conduct debriefings after PPH to evaluate team performance and also to identify areas for improvement. This is very essential. All labor room staff should undergo, including doctors and staff, all the nursing staff and other staff also. This is the take-home message. Thank you so much for the panel members and all the people who have been listening patiently. Thank you.
Thank you, madam. Thank you very much.
Thank you, madam. So I'm pretty sure everyone who had attended this webinar, it was a very fruitful and enriching session. And the management of postpartum hemorrhage will no more be a nightmare for any of the attendees. I thank Professor Dr. Kunyama ma'am, Professor Dr. Kurivila sir, and Associate Professor Dr. Rekha ma'am for this wonderful session. Before all of you leave the session, I just would like to remind all of you about tomorrow's webinar too. Tomorrow at 6 p.m. we have a webinar. It will be conducted by Dr. Tom George. It is a dive into the world of interventional radiology, uterine artery embolization for the treatment of fibroids. So hope to see you all of you tomorrow 6 p.m. Thank you all.
Thank you. Thank you.
Thank you.
Thank you, Prakash.
Thank you.
Thank you. Thank you.
Thank you, Sudhir, madam. Thank you very much.
Thank you, madam, for your patience
Excellent.
in spite of that
Excellent one.
interruption.
all the participants, all the staff also. Rekha and
Kuruvila.
Yeah, thank you.
Thank you, ma'am.
Okay. Can we leave?
Yes, madam.
Yes, madam. Everybody can leave.